Hello, my name is Arlene Stecenko. I'm a physician scientist whose career has been focused on CF. As a clinician, I've taken care of cystic fibrosis patients in Canada, Australia, and the US, and I estimate that I have taken care of over 1,000 patients with cystic fibrosis. My research is in cystic fibrosis diabetes, and that's what I'm going to talk to you about today. Clinical picture of cystic fibrosis diabetes is as follows. It is one of the most common complications in cystic fibrosis. It's a silent disease, and it slowly evolves with a period of prediabetes that can last for several years before you develop frank CF diabetes. It's diagnosed by doing an oral glucose tolerance test. And the CF Foundation recommends that we begin annual screening for CF diabetes using this oral glucose tolerance test at the age of 10 years. To diagnose CF diabetes, we measure blood glucose before and after drinking a glucose solution. So the patient comes in after an overnight fast with nothing to eat or drink other than water. We take a blood sample to measure the glucose level, and then they drink a glucose drink based on their body weight to a maximum of 75 grams of glucose. And usually by the time a person is a teenager, then they reach the maximum dose. We then measure blood glucose level 2 hours after the glucose drink. I want to give you context of what the 75 grams of glucose would be. And here are 6 8-ounce cans of soda. And the 75 grams would be 2 8-ounce cans of soda, which is not a great deal of simple sugar. Now that's for the teenager and adult. For a toddler, the amount of glucose that's ingested for this test is roughly half a can of soda, so not a great deal. So the definition is determined by the 2-hour glucose level, with normal levels being less than 140, pre-diabetes being 140 to 199, and CF diabetes over 199. And truthfully, with somebody with CF diabetes, their blood sugar may be 200, 300, or 400 after 2 hours after ingestion of this simple sugar contained in 2 cans of soda. So why is CF diabetes important? Well, it's extremely common. And what this graph shows you is the percent of CF patients that have CF diabetes based on age. And here's 5 to 9-year-olds with CF diabetes being in around 9% of them, and increasing significantly through the teen years, so that by the time a person is over 30, there's around 45% prevalence of CF diabetes. CF diabetes is also important because it accelerates decline in lung function. This graph shows lung function in people with CF diabetes in the yellow bar, or CF without diabetes. And we measure FEV1% predicted. With the higher the number, the closer it is to normal. And normal is above 80%. And you can see for each, and this is broken down into age groups, and for each age group, there's significantly lower lung function with CF diabetes versus CF without diabetes. And this is not trivial and can be anywhere from 5 to 8% lower with CF diabetes. CF diabetes is also important because it decreases survival. Mortality with poorly controlled CF diabetes is much higher than CF without diabetes. And death is due to more rapid progression of lung disease and eventual respiratory failure. So CF diabetes just makes the CF diabetes worse. Mortality is not due to stroke, coronary artery disease, or renal failure, as is the case in other types of diabetes. So CF diabetes really is its own unique flavor. When does CF diabetes begin? That's a great question. And this is where we've done the most research in Emory and children's. And so the old dogma was that CF diabetes was just due to damage to the insulin-producing cells as the patient ages. And so the older the patient is, the CF patient is, the more damage and eventually diabetes develops, what we call collateral damage due to aging. But the new concept really is that CF diabetes has its genesis in early childhood. And when we found that there's two primary defects in CF related to the development of CF diabetes. One is that there's decreased insulin function, and then the other is that there's an abnormal metabolism of glucose. Both of these are seen in CF, and I want to spend some more time on this to emphasize that there's a primary defect in CF patients leading to development of CF diabetes. The way we first discovered this was by performing research oral glucose tolerance tests in young CF children. When we do it clinically, as I've described earlier, we draw blood at 0 and 2 hours after ingestion and measure glucose. In these research oral glucose tolerance tests, we measure both glucose and insulin at multiple time points from 0, 30 minutes, 60, and 120 minutes after ingestion. So the Iowa group with Minnesota did oral glucose tolerance tests in 23 children aged 3 months, as young as 3 months to 6 years. And 39%, or 9 of these 23, were abnormal, with 7 having prediabetes and 2 having CF diabetes. We at Emory Children's did a similar study in 20 CF children aged 2 to 8 years. And of those 20, 25%, or 5 of them, were abnormal, 4 with prediabetes, and 1 with CF diabetes. And this CF diabetes was the 2-year-old. And what we found, looking more closely at insulin function, was that with glucose ingestion, there really was decreased insulin release in that first 30 minutes after the glucose challenge. I mean, let's pause here and talk about this a bit more. The insulin-producing cells in your pancreas are in this collection of cells called islet cells, and I'll show you a picture of them in a minute. But they're a collection of cells that these insulin-producing cells do 2 things. One of them, and the most important thing for CF, is that they preform the insulin and package it in little vesicles inside the cell, so that as soon as the blood glucose starts to rise, these packages are released and the preformed insulin goes in the blood and lowers the insulin levels. And we found that in these children with CF, that there's decreased amount of insulin release in that first 30 minutes, significantly decreased. And this goes along with what basic scientists are now finding, is that the CFTR protein is critical for release of that preformed insulin when the blood glucose level is rising. And that islet cells, or insulin-producing cells that have mutant CFTR, they have significant defect in this early release of the preformed insulin. So that first 30 minutes is the key, showing the defect in CF children. And the other defect is some interesting data from the group at Johns Hopkins. What I'm showing here is this is an islet cell, the insulin-producing cell. This is the organ in the pancreas gland. And the green are all the insulin-producing cells. And the islet also contains 3 other different types of cells that are represented in red that produce other hormones. And so these are islet cells from 3 different healthy toddlers. And you can see islet cells with primarily green or insulin production. Here are 3 CF toddlers of similar age, 3 different CF toddlers. And you can see much less green in the islet cells, much less insulin producing cells in these islets compared to controls. It's very striking. And so what we find is the primary defect in insulin function, insulin secretion in that first 30 minutes of glucose challenge, plus decreased number of insulin cells. That's a primary defect. We discovered another primary defect, and it's called Redox imbalance in CF. It'll take a little bit of time to explain this, but the way we discovered this was we did an oral glucose tolerance test in teens and young adults. We had healthy controls and CF patients that either had normal glucose tolerance, prediabetes, or CF diabetes. And what we did at baseline and at 2 hours after the glucose load, we measured systemic redox balance. And what this really is that there are couplets of molecules in your blood, And this couplet is really important for detoxifying the toxic oxygen molecules that are toxic to the cells. And these are supercharged oxygen molecules that are generated when glucose is in your system. And so these supercharged oxygen molecules are actually captured by these couplets. And these couplets sort of shuttle this toxic oxygen molecule down its pathway to detoxify it. And then it sort of restores itself to be able to take up again more toxic oxygen molecules. So we actually measured this couplet in the blood in these patients. And this graph shows this. And so you have to spend a bit of time here talking about it. First, we're going to look at the blue bars, which is the baseline or the degree of the couplet, the cysteine couplet in the blood. And blue is going to be before the glucose challenge. And what we see is that this is a healthy controls, and their couplet is at a balance of around -85. And when the numbers get less negative, that means the couplet is more oxidized and cannot detoxify as many oxygen molecules. So what we see with the healthy controls and the CF that have normal glucose tolerance, they have the right amount or balance. They're balanced in terms of the ability to detoxify the superoxygen molecules. However, with CF diabetes, prediabetes, and CF diabetes, they have significant reduction in their ability to detoxify any superoxide molecules. And so this is not a trivial amount. So it's the oxygen, the ability to detoxify oxygen molecules is reduced by around 10 millivolts. And normally with aging, we lose our ability or our balance to be able to detoxify these supercharged oxygen molecules by around 1 millivolt per 5 years. So these people with CF, prediabetes, and diabetes are actually having the imbalance that you would see in an 80 or 90-year-old. And these are healthy CF patients, teens and young adults. So they really have lost the capability to detoxify the supercharged oxygen molecules. What happens after you ingest the glucose on this oral glucose tolerance test? With the controls, they have no change. They're able to detoxify all those oxygen superoxide molecules and be able to detoxify them without any problems and restore the balance. However, all the CF patients, whether they had normal glucose tolerance, prediabetes, or CF diabetes, had severe problems at 2 hours in terms of they were unable to detoxify those oxygen superoxide molecules and were left with even worsening imbalance. So glucose caused production of these supercharged oxygen molecules, and the CF patients were completely failed to be able to detoxify them. And then this level of imbalance is very severe and would damage insulin producing cells. So this is a primary defect that we discovered, that glucose ingestion causes a severe imbalance in CF patients. So this leads us to our overall concept of how CF diabetes develops. That first, there's the primary defect. There's two primary defects. That CF results in abnormal insulin function, that is reduction in the number of insulin producing cells, as well as reduction in insulin secretion when you ingest glucose. But also ingestion of glucose stimulates this oxidant stress and redox imbalance in CF, and that leads to more damage and leading to worsening insulin function in eventually CF diabetes. So two primary defects, one in insulin and one in glucose metabolism. But then we think there's secondary factors that hasten the onset of CF diabetes. One is poor diet, particularly diet high in simple sugars. Glucose is a simple sugar. We have a lot of simple sugars in our diet. And so does this, when we ingest simple sugars in our diet, does this cause worsening glucose and oxygen stress? We have a small study that we found that during pulmonary exacerbations, which occur frequently in CF, that during these pulmonary exacerbations that are severe enough to require hospitalization, maybe a quarter of our CF teens are able to enhance their insulin secretion during the stress of this hospitalization through mechanisms that we don't quite understand, but that seems to protect the islet insulin producing cells so that following that hospitalization, they have not worsened their glucose status. Whereas those children that were unable to enhance their glucose insulin function actually had worse glucose status after the hospitalization. We think other secondary factors that might hasten the onset of CF diabetes is inadequate growth of the insulin producing cells. Now recall when, again, the size of the pancreas is the size of a cashew in a baby and size of a banana in an adult. And so these cells have to grow to be able to produce enough cells and insulin to be able to maintain glucose homeostasis. And finally, poor development of protective antioxidant mechanisms that we think perhaps some CF children are unable to develop these normal protective mechanisms and therefore are more prone to develop diabetes. I want to spend the last few minutes on the talk really focusing on this poor diet, particularly simple sugars. So CF patients need to increase their calories, the caloric intake, by 50% or more than a non-CF patient of the same age. This is to be able to maintain normal body weight. Sugars are an easy and less expensive way to increase calories, and kids like sweets. And I've shown you that ingestion of the simple sugar glucose results in rapid production of molecules toxic to insulin-producing cells. So what is the sugar intake in our CF patients? Well, first, let's talk about what the American Academy of Pediatrics recommends. And basically, they recommend children less than 2 years of age have 0 amounts of added sugar in their diet. And children 2 to 18 years of age are only limited to 6 teaspoons per day. So what are the foods that have added sugars? Well, 8-ounce orange juice, 6 teaspoons of sugar, simple sugar. 1 serving of syrup with pancakes, 8 teaspoons. So a breakfast of orange juice and pancakes with syrup already exceeds your daily requirements by more than twice as much. Add in a 12-ounce bottle of soda at lunch, that's 10 teaspoons. Maybe some iced tea at dinner, 11.5 teaspoons. And then a bedtime snack of a McDonald's vanilla shake, 24 teaspoons. So you can see our foods really have very excess amounts of added simple sugar. So we did a study to see exactly what our CF patients take in. And here's the daily sugar consumption in 3 CF patients and 2 healthy controls, similar age. These are school-age children. Each bar represents one day in one weekend day, and each bar is so 1 bar represents a day, and we did 1 weekend day and 2 weekdays. The horizontal line is the recommended daily maximum of 6 teaspoons. You can see none of the patients or the healthy children got close to that. This upper horizontal line is the US daily average, which is 3 times normal. And you can see some of the healthy children were able to keep the consumption for these 2 school days below the daily average. None of the CF patients were able to keep their consumption below the US daily average. And we have this one patient that on one day had 180 grams of simple sugar per that day, but a tremendous sugar load and well above the daily recommendation. Now, how much would they have taken in their oral glucose tolerance test? For this age group, it was around 50 grams. So you can see that, and we found that that amount of simple sugar in terms of glucose really causes the redox imbalance. And so you can imagine how much imbalance you may be getting with these high levels of glucose, simple sugar ingestion. So finally, what has our research telling us about potential strategies to prevent CF diabetes? First, the most important, identify those with poor insulin function at an early age by doing our research oral glucose tolerance tests, so we can really identify those that already have poor insulin function before it becomes overt in terms of the 2-hour oral glucose tolerance test. And identifying them early means we can prevent. We're in the process of determining what are the best diet intake to protect insulin cells. We're first starting with trying to decrease simple sugars. We're also looking at low glycemic index foods versus high glycemic index. Remember, low glycemic index foods are carbohydrates that cause a low, steady increase in glucose, whereas the high ones cause that rapid burst of glucose. We also want to know the difference between animal fat versus vegetable fat. There's evidence in type 2 diabetes that vegetable fat is superior to animal fat in terms of controlling blood glucose. So these are ongoing studies. We're also having studies determine how to enhance growth of insulin cells. And this is by seeing how insulin function is before and after starting highly effective modulated therapy such as Trikafta. And we believe that if we, that younger children, the toddlers and school-age children, if they're able to start on Trikafta earlier, that maybe we can then support them so that they can have the enhanced growth of insulin cells. And then these next two are a little bit more tricky to study, but we want to determine how to prevent loss of insulin function, maybe even boost it during pulmonary exacerbation. And this could be as simple as straightforward as when we identify children with poor insulin function, maybe they need insulin injections during their pulmonary exacerbation to help protect their insulin producing cells. And finally, we need to determine how to boost the redox system to prevent this imbalance during glucose ingestion. And there are some strategies trying to think of how to do that we're trying to develop. And so how you could help would be to help support this type of research, all aimed at preventing the development of CF diabetes by identifying those at risk early on, and then providing different strategies to support those insulin producing cells. Finally, I'd like to thank my wonderful collaborators and our superb team of research coordinators and the funding that we've received from NIH, the CF Foundation, and the FDA to fund this research.